Thank you for this kind introduction. I'm honored to be present here in Korea today. I hope my English is clear enough. My first language is French, so pardon me if I'm going to speak slowly. I hope everybody understands me well. So I've had the pleasure of reviewing the shared decision-making history for this talk, and it was really interesting to me. It's the first time I'm presenting this, but I had to go back to some memories and talk to friends about the beginnings. So, should I use this? Thank you. Just wanted to tell you a bit more about where I come from. So my university is located in Quebec City in Canada. So it's the French part of Canada. And you see here the first building of the university where I work, Université Laval. So it was the first French-speaking university in America. And this is my teammates. So the work I'm going to present about my group is a collective work. So I'm going to present what is shared decision making first. I know some people already introduced it a bit, but I wanted to really set the basis for everybody. How it started, the present state of the shared decision making research, the evidence, and then future directions. What are the challenges and opportunities for scaling and spreading shared decision-making, especially considering the initiatives going on currently in Korea? They're trying really to spread shared decision-making, so I thought it was timely to discuss this. So what is shared decision-making? So it's a process. Shared decision-making is a process first, where health decisions are made in a collaborative way between the clinicians and the patient, and where information is provided about the available options with their benefits and harms, and the patient's values, preferences, and circumstances are taken into consideration. So shared decision-making is about sharing of expertise. In a consultation room, there are two experts. First, you have the clinical expert. So they have expertise in the diagnosis, disease etiology, prognosis, treatment options, outcome probabilities. But on the other hand, you also have a patient expert. The patient is an expert. They know their values, preferences. They're an expert about their experience of their illness, especially when you consider chronic diseases. They have been living with this disease for a long time, so they know how they react to the disease better than the clinician. So they're really the expert of how they live with the disease. They also know more about their social circumstances. So if you propose a treatment to a patient and the patient doesn't have the means to do the treatment, doesn't have the funding, the money, or doesn't have the resources in their surroundings, for example, to get to the hospital, I'm working with older adults. Sometimes they can have mobility issue. So if you propose a treatment to them that requires them to move to a place and they don't have transport, so the patient is an expert in their social circumstances. They know about that, their resources. So because these two expertise need to be considered in making a decision, this is shared decision making, and it leads to optimal care. Optimal care is the care that is evidence-based, but also patient preference-based. So we have a lot of information at the moment about the strategies that allow to implement shared decision making, and there are three strategies that are well known and well studied. So the first of these strategies are the patient decision aids. Second strategy is professional education. And you can also have patient education that will promote shared decision making. So this is a bit less studied. The patient education piece is there's less research about that. The patient decision aid is a tool that it's not just like any healthcare information. It has some criteria So to make it a patient decision aid. And one important consideration is that the patient decision aid will have the pros and cons of all the available options. And there's never only one option. If there's only one option, it's not an option. So there needs to be at least two options. And the option of not doing anything, watchful waiting, should be part of a decision aid. So this is really difficult to implement because the doctor don't feel, and the clinician don't feel comfortable in waiting for later to delay the treatment. But sometimes an older patient doesn't benefit from having a very invasive treatment. So it's logical that they want to wait and they prefer to maximize their quality of life, and it's okay. So clinicians need to consider this. So we know that patient decision aids are effective. There's a lot of research. There's a very good review, Cochrane review. You know the Cochrane systematic reviews. There's a very good Cochrane systematic review. It's one of the most cited Cochrane reviews about the effectiveness of patient decision aids. We know they improve knowledge. They improve patient participation in the decision-making process. The decision aids are not useful only for patients. They're also useful for healthcare providers because in order to do shared decision-making, the provider needs to share evidence about the benefits of the options, and the decision aid will help them get up to date. So it's a bit an application of a guideline. For example, the guideline is a big document, but if you have a decision aid that reflects the state of the evidence, then you will have the evidence at your fingertips. So they also structure the clinical consultation, and this gives, in the end, that you will have a more seamless process because the discussion is structured. And they like the decision aid because they can distribute it to their patients. They're also useful for patients because they can read them before the consultation. So depending on when you distribute them, you can distribute them before a clinical consultation. So they will prepare the patient to have these discussions. They can be used during the consultation, but also if a decision is very, very important, very difficult, and the outcomes are severe, the person may decide to delay, and then they can bring the decision aid to their relatives, their family, and discuss with them. Now, the second strategy is professional education. There's also a lot of evidence about professional education. So usually the education will target skills, not knowledge. So it's more difficult to teach skills, right? It will also teach communication and ethics. So they may cover, for example, the role of shared decision-making in a safe, high-quality, evidence-based care, and how to encourage people to share what is important to them, sharing, discussing information to support shared decision-making. So a good training program usually will have feedback. So you will not only you will have probably like hands-on workshop practicing shared decision-making, and the teacher can provide feedback to the person on their performance doing shared decision-making. It's tough. Shared decision-making is tough to accomplish. So there are 4 steps for clinicians to implement shared decision-making. So the clinician should inform the patient that the decision is to be made, that the patient's opinion is important. The clinician should explain the options and the pros and cons of each relevant option. The clinician and patient discuss the patient's preferences. The clinician supports the patient in deliberation. And the clinician and patient discuss patient's role, make or defer the decision, and discuss possible follow-up. So we know already how to do shared decision-making. There's a lot of information and research about this. We know how to do it. We have the tools to do it. A third strategy is patient education. So there are 2 strategies. There are list of questions that you can teach the patient, and the patient will be invited to use these questions in a consultation. So one series of questions is from the Choosing Wisely campaign. So these are the questions here on the right-hand side. So for example, do I really need this test? The patient can ask that. What are the risks? Okay. There's another list of questions that are also often used for shared decision-making. The 3 questions, ask, share, know. Sometimes you can have interactive resources like application, apps, and videos. Karina, who's going to present after me, she developed a very nice video for patients to prepare, to understand what shared decision-making is, so then they can be more comfortable when they enter a consultation to say what they want and what they prefer. So how did shared decision-making start? So the forces behind the appearance of shared decision-making. So this was all happened in America and the United States, Canada, Germany, and UK. The first people who started thinking about shared decision-making were in these areas. So one of the person was Jack Wenberg in Dartmouth, and he observed a large variation in practice in the United States. So this work is very interesting. You will have the references in the slides if you like. So he thought, and they observed that when you do shared decision-making, you reduce the variation in practice. So this came later, of course. So paternalism of the doctor-patient relationship was also a force behind changing things and implementing shared decision-making. Ethical standards for informed consent. The rise of evidence-based medicine, and advocacy for patient rights and patient-centered care in the 1990s was also a force. So these are the people behind the shared decision-making movement at the beginning, but at least 4 of these people are still in my network and are still working. So it's very nice that we have this community where we can refer to these people that have a lot of experience. So Glenn Elwin is still doing work. I collaborate also with Adrian Edwards, so I'm not going to present them all. But Martin Herter in Germany. Maybe I would invite you to, anyway, So the basis, when they started doing shared decision-making, it was a network of people, so the people I showed you, and they decided to organize conferences. So the first conference was in Oxford, and it was more about, should we do shared decision-making? So at the beginning, they were discussing, should we do it? Is it practical? Is it feasible? And now the last one was in 2024, and we discussed how we should do shared decision-making in partnership with the patients, not just pushing down the shared decision-making, but having patients participate in the development of this new model. And also AI is really much at the forefront now. So the first questions that were really interesting people. So what is meant by shared decision-making? How does it provide value in healthcare? Is it ethically right? What are its essential elements? What conditions are necessary for it to occur? And the key focus was to develop theories, conceptual frameworks, or models to help answer these questions, but also to guide the teaching and implementation of shared decision-making. Because when you have a good theory, then you can produce measurement, right? So having a good understanding of the elements that are important for shared decision-making allowed to advance the research. So the first theory that was really published was the theory by Charles and Gaffney. And it described first what shared decision-making was by describing what it was not. So what is it not? So it's not paternalistic. The paternalistic approach is the clinician dominating the medical encounter, using his skills to diagnose and recommend tests and treatment for the patient. So in this approach, you have the doctor knows best. Patient involvement is limited to providing consent to the treatment advocated by the clinician. Shared on the other hand, is both parties take a step and participate in the decision-making process. So this was already in 1997, the first model, as I described. And then you may wonder, what is the other, right? The other side. So the other side, we call it the informed decision-making. So it's the patient who controls decision-making, and the clinician role is limited to communicate the needed technical or scientific knowledge to the patient. So this is not the best model either, because you don't benefit as much from the clinician's expertise. And I thought this was really theory. But at one point in my career, I was invited to work on hematology. And there was someone who invited me to develop decision aids for their group. And I learned about I don't know if you heard about the contaminated blood that happened in the 80s. So people with AIDS that requires a lot of, people with hematology problems, they require a lot of transfusion. And then there were problems in the blood banks that were contaminated by hepatic A and B. And so people started to be afraid of the doctors in the hospital. And these patients, they started to doubt the patient, and they adopted this informed approach. So they would not, they would look for the best doctor. They would go to a doctor. They say, oh no, I don't want this one. I don't want this one. So they would really be picky with the doctors, and they would be very cautious when they approach a doctor. So of course you can understand that this is not the best approach to care. Another very important model, so this is why I'm presenting it, because the first one, it was a bit general, but this one is interesting because it proposes 9 essential elements of shared decision-making. So I'm not going to read them all, but it was the model of Makul and Clayman. What is interesting is in that model, each of the elements, it's not defined who is doing it, who is defining, explaining the problem, who is presenting the option. It's leaving it a bit outside of the element. And also you see it's not always an action. So patient values and preferences is not something you need to do. It's just like an element of the model is not necessarily behavior. But this guided a lot of method development, and it's still used at the moment. So this is cited more than 2,000 times, this model. Some important milestones in shared decision-making history, so I'm not going to present them all, but there was in 1956, the first publication that mentioned elements of shared decision-making, the model of mutual participation. But the first time the term was used was in 1972. They really talked about sharing of decision-making then. The first review of the efficacy of patient decision aids, so remember I told you about the Cochrane review. The first version was published in 1999. In the implementation area, so the first decision aids were developed around the 80s by groups in the United States, and even then they were using the computers. Already they were developing interactive decision aids with computers in the 80s. So I would like to see that because I never seen these decision aids. And there was the foundation of the IPDAS, which is important. I'm not going to go into that. So there was a 2010 that was important for the society in general in the US because Obamacare included some legislation about using shared decision-making, and this has then had consequences because a lot of producers of decision aid arise in the US after that. There was also a ruling in the UK that established that patients should be told whatever they want to know in 2014, so this was important as well. So what's the current evidence? Are we ready for large-scale implementation? So the new forces behind the transition to shared decision-making at the moment is the quintuple aim for healthcare improvement. So I think you may be less familiar with this in Korea, but this is pretty much a new way of seeing healthcare improvement in all the Western countries. So you need to improve health, care experiences. So this fits very well with shared decision making. Limit costs, burnout in the healthcare workforce, and health equity. So there is evidence also about health equity, how shared decision making improves health equity. But we can now put in grants because of this new quintuple aim. Usually when I write a grant, I will say that my intervention will improve care experience and health equity, and this is a winning thing. So misinformation, like was exploded in the COVID crisis, is also now, I think, a new force behind the transition to shared decision making, because people are not as well informed. So there's a responsibility of the healthcare system to provide good information. This is a recent review of all the shared decision making models. And you see it started with the McCall and Clement model, and they added a few elements. I just wanted to show here in this slide that the new models, you see the models that are produced that only describe actions by the clinician. You see the green, the third one is the clinician. So most of the models for the elements, they consider the clinician role. There are less models that describe the patient role. So I think there is a gap there. That's my perspective, that I think we can also put more responsibility on the patient to also, activate the patient so they can support implementation. So the evidence on the strategies to implement shared decision making is very strong. So, I mentioned this briefly. So this is the systematic review on the effectiveness of decision aid, and you see now there are 209 studies. And I told you about the evidence already, that we know that decision aids improve knowledge, patient participation, they reduce decisional conflict. Oh, there it is. I did it in my memory, but it's all there. Improves knowledge, reduce decisional conflict, and improve participation in clinical decision making. So we also know how to develop decision aids. So there's a review of 280 decision aid development projects that created a framework on how we should develop decision aid. And what is the main message is that we have to do an iterative development process. So I create a prototype, I show it to user, I check what they understand, I check what is missing, and then I do a second version, and then a third version, and a fourth version, until the tool is doing its job, doing what it is meant to do. The decision aid is also advanced because now we have standards. So if you want to do a decision aid, you have to know these standards. It's important. So the standards have evolved since 2006. And so there are 44 minimal criteria that you have to meet to have a good quality decision aid. And these criteria ensure that the decision will not be biased. So you want, at the end of the process, to leave the decision to the patient. You don't want to, if you, for example, you develop a decision aid about the effectiveness of screening for prostate cancer, and you put a lot of benefits and just a little bit of harms, then it suggests to the patient that it's beneficial. So that's bad. So you have to have a balanced presentation. So this is the kind of criteria that you have. We know that if you have unbalanced presentation of information, the decision will be biased. You want the decision to be made by the patient, not really based on their preferences and not based on the information they receive. That's not what I mean, but you want the information to be objective, presented in an objective way. So the current evidence on shared decision-making measurement tools. So depending on the source, there are 17 to 22 tools to measure shared decision-making. the psychometric performance of these tools is not very good. So there are two recent reviews that really conclude that either the psychometric validity has not been well evaluated or that the methods are poor quality. So we need to do better. There are three constructs, three different dimensions that we can measure. So factors, antecedents, so factors that influence the shared decision-making process, for example, the patient level of education. We can also measure the process of decision-making, so the behavior of the people during the shared decision-making process. So you have two types of instruments. So observer instruments, where you will have an observer that looks at the consultation and rates. So it's an observer-based measurement. So there are several of them. There are about maybe 10 instruments. And there are self-report instruments. So most of these are patient-completed instruments, but there are some that are clinician-completed instruments. So they're more subjective. And then there's also decision outcomes, so feelings, satisfaction, attitude, etc. How can we evaluate SDM? So I recently reviewed the evidence on this question, and from all the research that has been done, I saw that there were two different, the self-report instrument by the patient are better to assess the relationship building aspect of a decision-making process. So, but the information exchange are better assessed with the observer instrument. So it's important, I think, to have the two types of instruments, because they don't measure exactly the same thing, even if they both measure the shared decision-making process. Because the process of sharing a decision is not just, I'm going to tell the patient the option, benefit, harms. How do you say it in Korea? You say, pali pali? I'm done. I say the options, benefits, harm. Okay, no. You need also the relationship. You need to have some kind of, the patient needs to feel comfortable to express their needs and express their preferences. So this part, you can only assess by patient telling you, yes, I felt comfortable doing the decision making. So this is just a representation of the observer instrument. This is the option 5. It's the most popular at the moment because there was the option 12, but this one is a bit shorter. So it's the one that's used a lot. So it's used by 2 or more independent and trained assessors. And the coding of SDM processes can be done in real time, but you can also record the audio recording of the consultations or the video recording. So there are 12. I was not too bad. I remember 10, but there are about 12 observational instruments. And items are inspired from the models. So you saw the models, the Mackle and Clayman model. So they were inspired from these models. So discussing the options. Did the clinician discuss the option? Did the two in the consultation discuss the patient preferences? Check. So what's our current evidence on shared decision-making implementation? So we have a lot of research on the development of strategies to implement shared decision-making. So I told you, patient decision aids, training. We have a lot of research to try it in rheumatology, nephrology, primary care. So we have a lot of research, and you can publish that. You can, because there's maybe a clinical situation that's very specific, and it's never been done, but you know, it's a bit redundant to try again to develop a new intervention and publish it. There's also a lot of people that are studying barriers and facilitators. And this is important because when you implement, you have to assess them and you can publish that. And there are reviews of barriers and facilitators now, and that's interesting. So is it comparable in different clinical contexts? Do you have some contexts where some barriers are more important? So that's interesting. Tailoring of strategies for specific population. Yes, that's a lot of that done. Evaluation of the effectiveness of strategies individually or combined. So you can have a study that will have only decision aids and one with decision aid plus training. So you have all of this. And monitoring the use of decision aid. This is less done. So often you will have a research project with a pre-post, a longitudinal follow-up, but then it's, when the project is finished, sometimes it's finished. So the future direction, and I want to go to scaling, challenges and opportunities. So research priorities for sustaining shared decision-making implementation. This is from the conference that occurred in Kolding. Karina organized that conference in 2022. And the research priorities that were mentioned by the participant to the conference are these priorities. So how can we ensure the long-term sustainability of shared decision-making in clinical practice? How can we improve synergy between shared decision-making and clinical guidelines? So yesterday we had a very good discussion with a person who's developing guidelines in Korea. And of course, just getting a panel of clinicians to agree on a guideline is one thing that's very tough. And then if you have to produce a decision aid, they have to agree on the numbers. And this takes so much time because they have to discuss and discuss and discuss. But this is a challenge. How can we support interprofessional collaboration to promote shared decision-making? So there are models for interprofessional shared decision-making. What are the most efficient strategies for implementing shared decision-making at scale? So this is a very important question, and Fritz and Karina are going to touch on that. How can technology enhance the quality, measurement, and sustainability of shared decision-making? So these are the strategies that we know a lot about. What are other strategies that could be added to this to scale implementation of shared decision-making? So for professional education, to scale shared decision-making, we know that train-the-trainer models are good. To have local opinion leaders or champions that will be, so if you in your clinical setting, you really bought to this, you're going to be a champion and you can contaminate in a positive way, you're going to contaminate your peers. And local support networks. For patient education, you can use the patient as partners, not only as subject. So you can help involve them in developing the education, in developing the strategies and implementing them. For patient decision aids, I think a good strategy is to facilitate the development of decision aids and improve the access. So, for example, in Canada, we have the EMR, the electronic medical record. So ideally, you would have the decision aid embedded in the electronic medical records. But I work in primary care. Each clinic have their different provider of EMR. So it's a big puzzle. But the ideal would be to have it, like you have the decision aid, you have the patient, and you have it at the fingertips. So I want to talk a bit about the facilitating the patient, the decision aid development process. So I'm working on this, and I developed the technology to support people who have not done a lot of decision aids to help them know more about the standards and develop the decision aid. So I provide a template on this website, and you fill the template and it provides you a decision aid that's interactive online. So at the moment, we're doing a research project to develop the platform, so it's still free. But eventually, and I want to disclose this, I would like to become a company so we can sustain. So my interest is sustainability. How can we sustain this development of decision aids? So the idea is to have decision aids that meet standards, that are free, public access, lower cost, not still costly, but lower cost. So I invite you to, if you want to collaborate and try to develop a decision aid with this, you can contact me. So you will have my email at the end of the presentation. The other strategies to scale implementation of shared decision-making are more at the level of the system. So if you're working in a hospital, in a clinic, in a province, in a country, it changes. So it's very dependent of your setting. So the legislative support, public relation, high-level leadership engagement, reimbursement scheme. So these are all elements that are important when you start scaling, and Fritz and Karina are going to talk more about that because it's a big challenge to apply that. And then when you want to measure how the process of implementation is working, you need to evaluate these elements that are not the same kind of measures. So are the decision aid acceptable? What's the adoption? Are they penetrating? So are they just used by the people to which you gave them, or do people distribute them afterwards? So all of these, I'm not going to go in the details, but I invite you to look at implementation outcomes such as these one when you're implementing an intervention. So the model of Macaulay and Clayman is still used today. So Fritz, this is a work from Fritz, and he used the Macaulay and Clayman to define another way of applying shared decision making. So this is a guide for clinicians. He's going to talk about maybe a little bit. I wanted to show you also another element. So a lot of people assess barriers and facilitators in a qualitative way. I think it's interesting, this scale, that I developed this scale to measure the level of the barriers. So from the barriers, we created a scale. And so we measure the perception of clinicians of their ability to practice SDM and to implement shared decision making. So it's a 8-item scale. So it's already validated in French, Canada, and German and Danish samples. So another important insight from the ISDM 2022 conference, it was the AI and technology. So how can we harness artificial intelligence for shared decision-making measurement? How can we use SDM data to drive real-time improvement in care? How can digital, so these are all questions that you can work on. I give them to you. You can use this question and try to work on them. So these are the questions that people, they put in a survey. The future of SDM, this is what it should be. How can digital innovation update the evidence behind patient decision aids? What are the barriers to using AI and digital recordings to capture the medical encounter? How can we support patients to use these systems to enhance shared decision-making and ensure they benefit? What unique opportunities and challenges do remote consultation bring to SDM? Teleconsultation that are now more used. So I'm working in this, where you see the arrow, trying to use artificial intelligence to measure consultation perform. So, as I told you, the observer scale is very, it requires a lot of energy. You have to have 2 observers. They rate the doctor and the patient relationship to see what's happening. So the idea that we had is to try to use AI to automate the assessment of consultation processes. So we have validated observer instruments. There's a lot of data set available because a lot of researchers did assess the consultations already. And there's a routine use of video recordings in Canada, in Quebec. When you train residents in the clinic, there are videos. I don't know if you use videos for training in Korea. So there are videos in the consultation rooms for the supervisor to support the training the clinician. So we already have this system in place that we could use for using AI. So we created a consortium. So we have about 40 researchers internationally now to work on this question. So you're invited if you want to join the consortium, you can contact me. So we want to co-produce an AI system with patients and clinicians. And, well, as I said, it's open to new members. So, and we don't have a lot of Asian people, so people from Asia, I'm sorry. So, we're trying to, if you do AI, you need to have a diverse data set. So your system will be useful for more people. So hopefully we would have a lot of people and data set from everywhere eventually. So you can learn more about that. So I want to tell, and I'm going to finish now. I just want to tell you about the ISDM Society, which is relatively new because the conference were happening before the society existed. And we are actively recruiting members in Asia. So now we're starting to translate the seminars that were in English. Now we use automatic translation to translate them in Chinese, now Japanese and Malay, I think. So we want to try to support people who don't speak English so fluently to try to become knowledgeable about shared decision-making. So we also want to facilitate implementation in all countries. So this is really one of the mission of the Shared Decision-Making Society. And so we are going to have a masterclass on the scaling of shared decision-making by Fritz in February 19 next year. So we're going to announce this soon. So if you're interested to join the society or just to know more, you can contact me. Oh, also there's a collaboration to establish a core outcome set for the evaluation of SDM initiatives. So I told you about the challenges that we have in measurement. So there's a group now working on this. And so the society is trying to support anything that's related to implementation of shared decision-making. And we do regular update on the state of evidence about implementation. So we did a number with 20 countries, the state of implementation in 20 countries. So this is you see the Bravo AI, this reference. So this is the editorial from a number with 20 papers about, okay, what's in Taiwan? What's happening in Africa? What's happening in, so it's very, very nice. So thank you very much for your attention.